So up next, we have Dr. Sarah Linke. She's an assistant clinical professor in the Department of Family Medicine and Public Health at UCSD, and also the assistant director of community engagement for UCSD's Institute for Public Health.
Okay. Hi. Thanks for having me today. So today I'm going to present about the development and the upcoming proposed implementation and evaluation of an evidence-based physical activity screening and promotion program. And this will take place in our 6 primary care clinics at UC San Diego Health. So this cartoon perfectly captures the message of my talk today. Evidence suggests that insufficient physical activity poses as much of a threat to patients as other risk factors that are traditionally covered during primary care visits. And insufficient physical activity is also very costly. In fact, it is accounting for approximately 11% of total costs in our national healthcare system. And so increasing physical activity among patients on a public health level could reduce costs as much as $76.6 billion. And you might have seen this quote before. It's kind of thrown out there a lot. And most people would probably agree with this frequently cited quote. So the question is, why is exercise not routinely prescribed? So despite evidence supporting the effectiveness and the cost effectiveness of physical activity counseling in a primary care setting, only 1/3 of patients report that their primary care physician actually covers physical activity during their visit. So key reasons for this include a lack of training and time that physicians have to cover during very brief visits. But what if a simple formula did exist for exercise to be prescribed? Would physicians prescribe it? So now we can begin to test this question using the program coined Exercise is Medicine. The prescription starts with a physical activity vital sign. And these 2 questions on the vital sign are multiplied together to come up with a total number of minutes per week. And if that number is less than 150 minutes per week, which is the recommended number of minutes per week of exercise, they're not meeting guidelines. So based on the PAVS responses, an exercise prescription can be easily generated and for each patient following the general guideline by the ACSM, which is approximately an increase of 10 minutes per week of aerobic activity. So these screenshots here for programming, their programming recently completed in EPIC, indicate that it is possible to integrate the physical activity vital sign and exercise is medicine prescription in our electronic medical record system at UC San Diego Health. Don't get overwhelmed by this busy screen. In the upcoming months, I'm going to lead the implementation and evaluation of EIM at UC San Diego. And I'm going to use a combination of PRISM and learning evaluation model. And I'll be breaking down this complex diagram in the next few slides. So you've heard a little bit about PRISM already today from Borsika, but just to remind you, it is the practical, robust implementation and sustainability model, and it evaluates how a healthcare program interacts with its recipients to influence program adoption, implementation, maintenance, reach, and effectiveness. The learning evaluation model is another methodological approach, and it combines quality improvement and implementation research methods to study healthcare innovations. It focuses on continuous quality improvement through rapid plan, do, study, act cycles. So first, I'm going to use PRISM to guide a comprehensive pre-implementation evaluation and adaptation of the exercise is medicine strategies. I'll then enlist physician champions and train clinic staff and providers to deliver the adapted EIM protocol. Next, I'll use the learning evaluation model to pilot, refine, and implement EIM within the 6 primary care clinics using rapid PDSA microcycles followed by learning meetings to generate ideas for improvement. And finally, I'll go back to PRISM and use that again as a guide to comprehensively evaluate the program's acceptability and potential for long-term sustainability within our UC San Diego health system. So what does this actually look like in terms of workflow? Well, here's an overview of the workflow. Prior to meeting with their PCPs for routine visits, patients will be prompted to complete the PAVS questions through the e-screening effort that we have now through e-check-in or in the clinic prior to their clinic appointment. PCPs will then receive notifications about these scores and be prompted to address physical activity with their patients. We are going to encourage providers to address physical activity regardless of the score, but for those who are not meeting the guidelines, they will also receive an exercise prescription using that automated system that is generated from Epic based on the patient's responses to the PABS questions. This will appear in the automated visit summary and be printed out with the orders for the PCP to sign. In addition, patients who are not meeting the 150 minutes per week of activity will receive a primary care behavioral health referral. Our PCBH providers will use motivational interviewing and shared decision-making techniques to address physical activity with those patients in a brief session that will cover exercise goals and potential barriers and solutions to those goals. And finally, this table summarizes the current annual numbers of patients completing PCP visits and the expected numbers of patients to complete a physical activity vital sign, exercise prescription, and complete a PCBH referral. Thank you very much.
We have time for a question. Oh, great.
Hi, I was just wondering, how are you monitoring compliance to the exercise intervention, and how long are you expecting them to be engaged in it?
For the provider, on the provider's side or the patient side?
For the patient.
So this is actually more focused on the provider side. So it's an implementation method to try to increase physical activity promotion on the provider side. Actual compliance with the physical activity will really only be monitored through those 2 questions that they will then be asked to complete each time they come into the clinic. But it's all self-report. So the main focus is really on how can we change the system-wide level to get the providers to prescribe exercise, because we've known that that's really effective for years, but we haven't really found a way to get it to actually happen on a regular basis in the clinic.
Right. It just seems like the next logical step then will be in terms of prescribing the exercise and telling them what to do and how to keep them engaged in that. So
yeah, definitely. Yeah, we're hoping to eventually get devices integrated within our system so we can monitor that. But first, we just have to get clinicians to address it in the first place.